Hello everyone. Good morning, good afternoon, good evening, depending on where in the world you're joining us from today. I'm Emma Kinloch. I'm the founder of Salivary Gland Cancer UK, and I'm absolutely delighted to be speaking today at the Swallows 2020 International Head and Neck Cancer Conference. I will be talking about the importance of collaboration between patients, carers and health professionals, and I'm going to be using the story of how Salivary Gland Cancer UK came to be to demonstrate the power of these collaborations. So without further ado, let's get started. I was diagnosed in the summer of 2012 with a rare salivary gland cancer called adenoid cystic carcinoma. Now you may remember that 2012 was the year that the Olympic Games came to London, and I am a Londoner. Yet I did not see one single event, despite the fact that they were taking place very near to where I live. I did, however, have surgery for my cancer, and that was followed up in the autumn of that year with radiotherapy. During my treatment and recovery, I quickly realised that there was a large area of unmet need and many challenges associated with this cancer. For patients and carers, and for their treating clinicians, and for researchers, I wanted to do something to change that. Before I go into the detail of what we've done, let me tell you a little bit about salivary gland cancers and why they are rare. So I always used to think that something rare was great, gemstones, diamonds, they're rare, saffron's rare, going to the South Pacific is rare, all good things really. However, rare diseases and rare cancers are not good things. Salivary gland cancers, despite the fact that there are over 23 of them, they only represent less than 0.5% of new cancer cases globally. Adenoid cystic carcinoma is the most common of them, and that affects around 5 people per million per year in the UK. So ACC arises in the secretory glands and is most often found in the head and neck, in the parotid or the submandibular glands, but it can also occur in the trachea, in the lacrimal gland, the breast, the skin and the vulva. ACC has many specific challenges, and I'm going to start by describing them before telling you what we've done to address them through collaboration. So firstly, the challenge of getting a diagnosis. So ACC is an equal opportunity cancer. It shows no bias. It is not inherited. It is not associated with lifestyle choices such as smoking, and it's not associated with ethnicity. It can strike at any age, and the average age of diagnosis is younger than for other cancers. Quite often patients don't show symptoms, they're asymptomatic, and when you do have symptoms, because there are no clearly associated risk factors and no links to gender or age or ethnicity, they can be easily mistaken for less serious conditions. So for example, if you're a 25-year-old young man and you're a marathon runner and you suddenly develop, breathing difficulties and you go to your GP, they might well think that you have asthma or an allergy. They're not likely to necessarily think first off that you have a cancer growing in your trachea. Similarly, if you're a woman in your mid-30s and you have a very stressful job and you grind your teeth, if you start getting pain and shooting pains in your face and neck region, the first assumption may well be that you should change your job and stop being so stressed and grinding your teeth, not that you've got a bowl of cancer growing in the middle of your head. To add to the complications, ACC may not show up on scans. So PET scans rely on the cancer cells eating glucose quicker than the other cells, and ACC doesn't always do that. So it can show up as negative on the PET scan, or not show on the PET scan. Doesn't always, but sometimes. And ACC looks different to other tumour types. It grows along nerves, and it usually grows very slowly. So assuming you've overcome the challenges of getting a diagnosis, the next set of challenges you face are around treatment. So because diagnoses are often later, people are often diagnosed at stage 4, this means that they have more radical treatments. More radical treatments mean poorer outcomes, an increased use of extensive surgery. Patients lose their eyes, their jaws, parts of their tongue, and they may need to be reconstructed, they may not be able to be reconstructed, and they may use a prosthesis for the rest of their life. If a tumour is inoperable, they may be treatable by radiotherapy alone. Until recently, we didn't have proton beam therapy as a treatment option in the UK. That's changing, or has changed. But we still don't have carbon ion treatment in the UK, and there is no referral mechanism to the European centres for that treatment if that would be appropriate for you. So surgery and radiotherapy are the main treatment options for this disease because there are very limited, in fact not really any clearly identified or available targeted drug therapies or chemotherapies. So if you are a patient with an incurable or metastatic disease, current chemotherapy regimes have very poor results. Further complicated by the fact that ACC likes to metastasize, and you can have metastatic growth even appearing after 10 years of being cancer-free after your treatment for your primary. Patients require, therefore, ongoing monitoring for many years, and ongoing scanning for patients has its own unique set of challenges. So those are the challenges for treatment. Let's also just talk a little bit about the challenges for research into these cancers. So very little is known about the biology of ACC, and as I said, there are no targeted drug therapies available at the moment, and there is limited research. I must say though, in the 8 years since I was diagnosed, this has got considerably better. There are lots more people working around the world on this, and information is feeding through, and trials are underway, so it is much better than it was. But at the time that I was treated, there was a massive unmet need in research, and very little, in fact nothing really, well, very little was being done in the UK. And that's not to take away from the people that were doing amazing things. There wasn't some limited research and going on, but there was a lot more needed to be done. Low patient numbers for these cancers mean that it's hard to get the right number of patients in a trial, and if you don't have a significant number of patients in a trial, then you don't really prove anything in your trial. So do we need to be clever about trial design? Do we need to think more about basket trials where you have different types of cancers all in the same trial? And do we need to think more cleverly about drug repurposing? Interestingly, I wonder whether the drug repurposing and the very quick trial delivery, or getting them up and running for COVID, I wonder if this will affect cancer research trials in a positive way. Let's hope so. Other challenges of research include the need for international collaboration, to get those numbers, to share, understanding, to share data, to share results. Will this be affected by Brexit? We still don't know that yet. Challenges are also that when you collaborate internationally, do you have the same sort of data set? Are you looking at the same things? I think from a financial perspective, if you're a pharma company and there's sort of 5 patients for every million, that's less financial incentive for you to work too hard on that, rather than if there were sort of 50,000. And where there is research, then the last point here is that actually getting access to those trials, how do we do that? Are we able to move through Europe, through the world to access trials? Are there cleverer ways to do that? So overall, a greater understanding of these cancers is needed. And the last point about the challenges of these cancers is, I'll go through this very quickly because I'm sort of singing to the choir here, that you will all recognise a lot of these points. But specifically to salivary gland cancers and adeenoid cystic carcinoma, there was a lack of sort of specific information and UK-based specific support. Some treatments, especially experimental treatments, we don't know the consequences of them. The challenges also of living with a chronic condition, the added complexity of metastatic disease and ongoing monitoring. And then, as with all cancer patients, and certainly all head and neck cancer patients, and certainly for this group of cancer patients, there is the ongoing fear of recurrence, fear of death, and anxiety about having scans, and anxiety about not having scans. And then for many, there's the aspect of post-traumatic stress from having had the diagnosis and been through the treatment, because it really is quite a thing. So, just a few areas to address then. And after I had been treated, I had set up a support group in the hospital that I was treated in. And I started it in collaboration with a nurse, a CNS. And we still work together today on it a number of years later. To my great surprise, it was actually running really well. And it was starting that group and recognising all these challenges and unmet needs that put me on the path to being here with you today. So before I go any further, let's just ponder for one moment exactly what collaboration is, because that's what I'm going to talk about. So let's just start with the definition. Collaboration is the action of working with someone to produce something. I would also say that some of the keys for successful and productive collaboration is listening to others, learning from them, accepting different viewpoints, experiences, and perspectives. We need to embrace diversity, and we need to use it to strengthen the work that we're doing and to generate the best outcomes possible. After a while of running the support group, my attention was drawn to the National Cancer Research Institute in 2015. The NCRI have a number of research groups, and they're focused on specific cancers and working in a collaborative way, bringing together all members of the MDT and beyond and the patient voice to move forward research in cancer. I ended up joining the head and neck group, and I was a little upset initially that there were no ACC or salivary gland cancer trials. So imagine my amazement one day when I'm on a conference call and a researcher called Dr. Robert Metcalf comes on the line, and he suggests an ACC trial. I literally could have reached down the phone to shake his hand, and from that moment on we started collaborating to meet the unmet needs for ACC and salivary gland patients and move forward research. So how have we done this? Well, what we've done to address the unmet needs was starting a charity. In April 2019, Salivary Gland Cancer UK was launched. As I've outlined, it is a unique collaboration between a patient advocate and a medical oncologist. We use co-production to build an active patient and research community, and we think we're quite unusual in that we're founded by a patient advocate and by a clinician together. We want to understand the biology of salivary gland cancers, we want to advance research, develop new treatments, we want to provide peer support, reliable information to patients and carers, we are developing a network, and we want to create the network to be unique. Clinicians and patient collaborators across disciplines and across regions to include all interested parties in our work. Patient-carer involvement is represented in everything that we do. Our philosophy is that patients shouldn't be used on a consultative basis in terms of inputting into strategy and research. They are not a box to be ticked on the form. They are integral to all levels of the process. So with that, I'm now going to talk through some examples of how we've used these collaborations to move things forward and to show you just how powerful collaboration can be. So let's start with how we've used patient-carer and clinician collaboration to move things forward. We have regular meetings, primarily for patients and carers, but attended by clinicians and open to all. We usually have around 30 to 50 patients and carers, and we gather 4 times a year. We used to do our meetings in person, but sadly, and we all know why, we now use Zoom, and I very much hope that that will change in 2021, but we shall see. In our meetings, we always provide patients and carers with an opportunity to share their stories, and then we follow up with a research update from the clinicians so they can understand the work that we've been doing and what's been happening in other places worldwide to drive forward our shared goals, need for better research, and ultimately improve outcomes for patients. We also have guest speakers to address any topics that the group wants to hear about. So, for example, our last meeting on October the 31st, we had an address by a psychologist to talk through post-traumatic stress and anxiety. We always want to respond to our attendees, and we're really open to agendas and who we have present in our future meetings. We found that one of the great things about having clinicians there is that we can answer a lot of questions on the spot. And just to reiterate the point, these meetings are open to all, and at the end I'll share contact details, so if you did want to join, very welcome. The second thing we've done through our patient-carer and clinician collaboration is that we have trial discussion days. So where a researcher or a clinician has a trial proposal, they can come and present to a group of our patient network. And this ensures that patient input is there right from the start, and that the trial is thoughtful and developed in a way which makes sure that patients take part. No trial is any good if no patient takes part in it. Trials need patients. Therefore, it's important that the design is appropriate and isn't asking patients to do things that they quite simply won't do, especially at the moment when we are in a resource-constrained environment. There is limited funding for trials, and that is likely to continue for a little while. So the patient input at this level is hugely important. The third thing is our SGC UK strategy days. So we gather a group of patients and clinicians together, and we talk through what is important to them. And we feed these into our organisational priorities. It's patient and carers' chance to tell us what is missing in their journey so far. What can we do to move it forward? And early 2021, we very much look forward to sharing our 2021 priorities based on these discussions. The collaboration has also raised awareness, so with both clinicians and patients telling people about us and what we do, we've managed to grow our network significantly in the first year. We've got leaflets to send out to people, so let us know if you would like one. Or several, rather. So the next area we've been able to significantly develop in and collaborate in is our UK-wide collaborations. So we've managed to extend, and I'm delighted to say that clinicians are now referring patients from all over the UK and beyond to our specialist hub at the Christie NHS Foundation Trust in Manchester, which is where Dr. Robert Metcalfe has his clinic. He also has a biobank there of tissue samples, which is being built up to feed research both in the UK and internationally. We had a clinical trial open last year at the Christie Hospital for ACC patients, which was amazing. We also collaborate with the National Cancer Research Institute and their Consumer Forum, which is a group of patients and carers who are interested in research across all cancer types, and I currently chair that forum. And patient and carer support organisations. Obviously, we collaborate with those as well. But patient and carer support organisations are the focus, not just in head and neck cancer, but also in rare cancers as well. Next, we collaborate internationally. So Robert Metcalf and myself are part of the International Rare Cancers Initiative, and this is a great example of where information learning and cross-fertilisation of ideas takes place around the world. As an organisation, I and myself, we represent salivary gland cancers in Eurocan Domain 7, the rare head and neck cancer domain. We collaborate with patient organisations such as Uroidus. We collaborate with research foundations such as the ACC Research Foundation, and we undertake project work internationally, developing international guidelines, looking at building a registry, developing and delivering training courses. The last area that I'm going to mention is our patient-carer collaboration, and since we started over a year ago now, this has just been amazing. On an individual level, patients providing support to each other has just been overwhelming sometimes. We've given people the opportunity to meet others with the same disease for the first time. We found that there are networks of patients out there, but with no organisation to give them a home before now. So when we had our acidic cell focus meeting, I had a couple of patient contacts, and through them we had 10 people join. Now, 10 people is not a big number, but it's a big number for acidic cell carcinoma, and these patients had developed their own little group internationally, and now they can come and be part of our group and have a bit more structure, and it was just amazing. And that's been one of the great things as well about the last year, is we've expanded from adenoid cystic carcinoma into supporting all salivary gland cancers. The second thing is sharing information. Patients and carers have just been amazing in supporting us, providing information about us, providing information to us, what we're doing, what we are going to do being shared through Twitter and Facebook. I mean, it's just been amazing. And we're constantly updating the information we have, and we see people sharing, so thank you everyone that's done that. We've seen our patient-carer collaborations expand awareness with clinicians, patients telling clinicians about us if they didn't know about us, getting clinicians to refer patients to Dr. Metcalf. Our consultative committees, either for temporary, as I've outlined, or more permanent, and we'll be building those out in 2021 with the help of all our patients and carers. So the last thing I want to mention is at an organisational level, and this is from a personal level as a patient advocate. So we collaborate with a number of organisations focused on head and neck cancer support, research and rare cancers, as I mentioned earlier, but I just want to expand on that. It's not always easy doing patient advocacy. It's a lot of work. It takes a lot of time. Often you're not paid for your time, and you have to work quite hard to establish yourself. People share their stories, they share their pain, and they share their suffering, and some people die. Sometimes you can feel that none of it's helping and you're not getting anywhere, But then you remember that if just one person feels less alone or enters into a trial that could save their life, then you've done something, and it's a good thing. Quite simply, collaboration is the key to the success of all of this. Collaboration between patients, carers and health professionals. We need each other. We need to work together. We quite simply need to work together to move things forward for us all. This is my last slide. I just want to say thank you for listening. Launching Salivary Gland Cancer UK as a unique collaboration is addressing the unmet needs for salivary gland cancer research in the UK and beyond for clinicians, researchers and those affected by these rare cancers. A valuable database is being established to drive forward national and international research. Reliable information and support is being provided for patients, their carers and treating clinicians. And there is so much more that we're planning, but I don't have time to tell you about that here and now. But please know we are open to collaborating with all of you. Please get in touch if you're a clinician, patient, carer, healthcare professional, pharma company, or just interested in salivary gland cancer and working with us. Contact details are here. You can join our network, email us, tweet, or join us on Facebook. The very last thing I want to say is thank you to everybody that has supported us so far. And within that, thank you to Chris and Sharon and the Swallows. Thank you for inviting me to speak. Thank you for your amazing work. Thank you for your support. Thank you for your collaborative spirit. I'm very much looking forward to the rest of the conference. And with that, I will say goodbye and thank you all for listening.